Surprise, surprise, pulmonary embolism.
So to add to the sort of growing number of devices that are coming, it's my pleasure and on behalf of my co-investigators to present the ENGULF trial. Here are my disclosures. So as a background, we know that mechanical thrombectomy, which is now a primary strategy for the treatment of pulmonary embolisms, has 3 new devices achieving PE indications. However, despite this, challenges with clot removal remain, and that includes vascular injury, hemodynamic instability, and inordinate blood loss with large bore catheters, incomplete and ineffective clot removal with small or moderate bore catheters, and then finally, catheter corking and challenges with removing organized or larger fibrotic chronic clots. And so what's needed in this space is a dual mechanism moderate bore thrombectomy solution, which is what this particular catheter offers. I'll give you a more representative example of this in a video format, but this is the Hēlo PE thrombectomy system, which was studied in our trial here. The most unique portions of this particular catheter is the expandable funnel, and what the device is actually transits through the body in a 16 French sheath compatible system, and once you get to the target pulmonary artery, the expandable funnel expands out to 24 French. Inside of the funnel, you're able to advance a agitator device, which will spin and allow for that corking solution to, for the larger chronic clots to be engulfed inside of the device, pun intended here. So I'll show you a representative video of this. What's interesting about this particular device is that it was built to mirror some of the angulations seen in a bronchoscope. So there are 2 articulated bends, and in the integrated handle that's outside of the body, this is the agitator that's actually inserted into the catheter. It does not get exposed to the body, and it spins at the behest of the operator, who has the full ability to control aspirations as well as agitator activation. What you're not seeing here is that on the integrated handle, the operator also does have the ability to spin each one of these angulated bends in the catheter so that you can have full articulations and full 360-degree motion of the catheter itself. So the objective and trial design of the ENGULF trial is a 2-phase prospective single-arm study that assesses the safety and feasibility and efficacy of the Hēlo PE thrombectomy system. We report to you now the feasibility phase, which enrolled the first 25 patients as a first-in-human device, and then we are now moving forward with the pivotal IDE phase for our next phase of study. I'd like to obviously thank our enrolling sites and our national PI who's sitting here in the corner, Dr. Jay Geary. Before we start going into the actual key inclusion criteria here, we included those patients that had intermediate risk PE as defined by the ESC criteria. You could see the age range of 22 to 90, symptom duration of less than 2 weeks, and evidence of proximal PE by CTA with an RV-LV ratio of greater than 0.9. Systolic blood pressures that were greater than 90 millimeters of mercury and a heart rate of less than 130 beats per minute. Key exclusion criteria were those patients that have pulmonary arterial systolic pressures of greater than 70 millimeters of mercury by right heart catheterization prior to the actual insertion of the catheter. And you could see some of the other key exclusion criteria that are listed out here, with the notable one being an FiO2 requirement of greater than 40% or greater than 6 liters per minute at the time of inclusion. The primary and secondary efficacy endpoints for the trial: the primary endpoint was the reduction of RV-LV ratio on a CTA from baseline to 48 hours post-procedure, with secondary outcomes looking at modified Miller score reductions as determined by a CTA core lab, as well as a reduction in target clot volume as determined by an angiographic core lab in targeted PA arteries. Primary safety endpoints included device-related major adverse events at 48 hours as defined by an all-cause mortality and VARC2 criteria major bleeding. Device-related serious adverse events were defined as clinical deterioration, pulmonary vascular injury, or cardiac injury. Secondary safety endpoints are listed here. We did have 2 core labs that adjudicated our data. One was for the CTAs and one was for independent angiographic core lab data. Here are some of the baseline characteristics of who we were including into the trial. You could see that the mean age here was in their 60s. As well as key baseline characteristics at the time of inclusion into the trial, you could see that the mean systolic blood pressure was 130. Notably, there were no patients that were included with a systolic blood pressure of less than 90 as per the trial, as well as an elevated troponin and BNP levels in 71% of the patients, representing a high intermediate risk cohort. The procedural characteristics you can see here is the baseline pulmonary arterial systolic pressures were in the 50s with a mean procedure time of 57, and you can see the blood loss and length of stays listed here. Primary safety endpoints, I'm happy to report that there were no device-related deaths within 48 hours, major bleeding events within 48 hours, and the two SAEs found within 48 hours were for transfusion but did not meet the a priori definition for VARC2 bleeding. Similarly, secondary safety endpoints at 30 days were, again, no clinical deteriorations, mortalities, and the same two device-related SAEs at 30 days. I'm happy to report that our primary efficacy outcome for the trial of ENGULF showed a mean reduction of RV-LV ratio of 23.2%. And you could see a representative picture here of a targeted pulmonary artery that had thrombus within it that underwent the procedure, and you could see the nice result that we are seeing here. When we take a look at the RV-LV ratios in comparison to those devices that are already FDA approved, these are some of the other devices that we were in comparison with, and you could see that we are in comparison with the RV-LV reduction in some of the other FDA approved devices, suggesting that the efficacy for this first-in-human device is actually comparable to some of the other already FDA approved devices out there. Secondary safety endpoints, looking at the reduction in modified milliscore, you can see that this is a clinically meaningful modified milliscore reduction, as well as reduction in thrombus burden based upon pre and post thrombectomy pulmonary angiograms as adjudicated by an angiographic core lab, shows an 83% reduction in targeted PAs by the device. However, this was only performed in 12 of the patients. So limitations here of our study, it's a feasibility phase result, and pivotal IDE phase is ongoing. It did not assess for long-term clinical outcomes. And of course, all patients were intermediate risk, so generalizability to other risk stratified are clinically not determined as of yet. Pre and post angiography are only available in 12 patients. And so the angiographic portions of this, again, have limited generalizability. So in conclusion, in this multi-center feasibility study, the Hilo PE thrombectomy system reduced the RV-LV ratio by 23.2% without any major procedural or 30-day complications. However, a prospective IDE-approved pivotal study is currently underway. I'm happy to report that this was already published on JSCAI today, and you can read more about it at the link below. Thank you.
Congratulations on a trial well run. I'll go to my panelists. Alyssa, in the realm of pulmonary embolism treatment, as we've alluded to, there's many devices out there. Is there any changes in how we can approve in terms of safety outcomes? Anything else that we can improve upon based on what we know? Is there any bars that need to be lowered? Are we always going to look for RV to LV ratio change? Are we always going to look for a hemoglobin drop? Is there anything else that you would want to look for in a pulmonary embolism trial?
Well, I think as we accumulate longer and longer term follow-up on these patients, some of those patient-related endpoints could be really important. And identifying as a group what those endpoints should be that can subsequently be incorporated into the longer term studies will be really important.
Ty, congratulations. This was through an EFS pathway, this 25 patients. What was the exact pathway that you guys decided to do this 25?
Well, so this was actually discussed with the FDA and the company as well to undergo, and I congratulate our sponsors here for actually taking the time to do a feasibility study with 25 patients to go through. Right. I could tell you as a user of the device, it's not a difficult device to use, but it does take a couple of iterations for you to kind of get comfortable with the device. And so we thought it would be important to at least include 25 patients up front just to make sure that we understood what the feasibility of this and efficacy looked like. There have been several other studies that have been put through in terms of first-in-human devices that have had smaller sample sizes, and we thought that as an investigator panel that we needed a more robust collection of patients to really make a good understanding of what the efficacy of this device would be.
So that, of course, begs the question, what's next?
Yeah, so the IDE trial is currently underway with a larger experience of patients that we're going to be including. Obviously, as Dr. Keeling said, this is one of the newer players into the market. And of course, we're still waiting for randomized control trials to determine whether or not, embolectomy over heparinization or even ultrasound-guided, ultrasound-assisted CDT is going to be more efficacious than heparin. But again, this is exactly what we've been discussing before, is what is the role of these newer devices. But this is one of them, and it's very exciting. I think we're seeing a renaissance here that we're living through.
Ty, I got a question for you. I've already talked, so I can be a little bit more critical, thankfully. Tell me a little bit about the agitation. And the only reason I ask, and it probably harkens back to the angiojet experience, is it possible without continuous suction on the cannula for you to agitate some of the clot and for it to embolize distally with this device?
So, what I didn't actually impress upon you is that there's actually a two-step like a button on there. So what that means is the more pressure you put on this button, the first half is actually aspiration alone, and it's only when you depress fully that the agitator turns on. So to answer your question, there's not an option where you can just turn on the agitator without suction already being in place. So it's a great question, but it was designed and engineered in that way to prevent things like the agitator shooting these things forward.
That's reassuring. Thank you.
Any other questions from the audience? All right, well, with that, thank you, Ty. I appreciate you.